left kidney had 3 stones and the right kidney had a stone of 20 mm in the renal pelvis. The HU value was more than 1000. So this patient was planned for supine tubeless mini-PCNL. So this is a cross-sectional image of the patient showing the bilateral renal calculi. The right side stone was in the pelvis. So first right side supine tubeless PCNL was planned. So we usually place the patient in FOSML position, that is flank oblique supine modified lithotomy position. So we place a bolster below the buttocks on the operative side. Then we mark the posterior axillary line, and the 12th and 11th ribs are marked. Usually the 12th rib crosses the posterior axillary line, but here as the ribs was small, so it was not crossing the posterior axillary line. So after painting and draping of the patient is placed in this position, painting and draping is done. And then here, first of all, we puncture the kidney in after doing pyelogram. We select the calyces to be punctured. Usually the posterior calyx is punctured. So when we do the pyelogram, the contrast by gravity settles down into the posterior calyxes. So we target those calyxes which are dark. So after selecting as the stone was in pelvis, so we selected in this patient a lower calyx puncture would be a better option in this patient rather than going supracostal. Even we can go supracostal also. Puncture is can be easily done even in supine position also. So here the stone was found in pelvis, so we went ahead with the puncture in the lower calyx. First of all, the C-arm is rotated because the patient is placed in a 20-degree flank up position. So we usually do minus the size of the C-arm. That is, we instead of bringing putting the C-arm on our side, we do minus 20 degree of the C-arm, so that the kidney lies in the 0 degree. So first of all, after doing a pyelogram, we select the calyxes, and then the calyx is punctured under 0 degree first. So we have selected the lower calyx, and then we will be puncturing the lower calyx. So as the needle is advanced in the lower calyx, then we see is the needle anteriorly or posterior to the targeted calyx. So we rotate the C-arm towards the head end. So if in the 30 degree, if we turn the C-arm in 30 degree towards the head end, and if the needle doesn't change its position, that it is in the same position as in the 0 degree, that means we have hit our calyx. If the needle moves a little bit upwards to the targeted calyx, then we again withdraw the needle, and again we go a bit more anterior. And in case if on rotating the C-arm on 30 degree or a 15 degree, because with experience you can do a puncture in 15 degree also. So if we rotate the C-arm on the 15 or 30 degree, and if we see the needle going posterior to the targeted calyx, that means that we have not hit the calyx and still we need to go posterior. So again we rotate the C-arm in 0 degree and we push the needle posteriorly so that we hit the calyx. So here actually in the 15 degree or the calyx is directly hit. So, and we can see the clear fluid also coming through the needle. So then we place the guide wire into the into the system. Then after parking the guide wire, we do track dilatation with the help of Teflon dilators. Usually we do single dilatation, that is 10 French, and then after doing dilatation we place the guide wire straight forward. So the guide wire and all these things are done under fluoroscopic guidance. So after placing the guide rod, we advance all the metallic alkane dilators. Usually we do 14 French and 16 French punctures routinely for the tubeless supine PCNL. If the stone size is less than 20 mm. So here we have dilated a tract. We have inserted 3 metallic dilators. Then after that, we are placing a 16 French M+ sheath over the dilators. And we advise the assistant to continuously push the line from the ureteric catheter, so that if there is any clots or any small fragments are there, that can also expelled out with the help of the irrigation. So then we use the the after placing the amplas sheath, we insert the mini nephroscope, and then the stone is located, and then the stone is being fragmented with the help of holmium laser. We try to fragment the stone as small as possible, so that because of the gravity, the stone is itself it expelled out of the system. Actually, if we are in the lower we have if we have targeted the lower calyx, I mean the posterior calyxes, then because of the gravity, the fragments are going to easily fall out of the system. We did not pick up these fragments. In case if needed, we can even pick up those fragments with the help of forceps or with the help of basket. So once all the fragments have been removed, then we place a guide wire so that a digest stent can be inserted. So all these things are done under fluoroscopic guidance. So after placing a, guide wire, digest stent is slided over the guide wire. And because the puncture is very small, the tract size is very small, there is obviously no such more bleeding can be seen. So after successfully placing the digestant into the system, we withdraw our amplas sheath. We make sure that no other related other organs, nearby organs, has been injured. So usually we come out of the system after inserting a guide wire. So we gently withdraw our amplas sheath and see that if had any other organs has been injured or not. So this is one of the good technique of coming out of the system. So after that, because the tract size is very small, so we don't routinely put tubes in our patient, and all these cases are done under spinal anesthesia. So even we can discharge this patient within 24 hours. So that is the ambulatory tubeless supine mini PCNL that we do routinely in our practice. Thank you for watching the video.